And next, I want to introduce Dr. James Hunt, who's going to give us our didactic session. Dr. Hunt's an adjunct associate professor of anesthesiology in the Department of Anesthesiology, and also a division of pediatric anesthesiology and pain medicine at Arkansas Children's Hospital. So, Dr. Hunt, welcome, and we look forward to hearing your presentation.
Thank you for having me. I'm going to see if I can get my shared here. Can you see the screen, Brian? Okay. So everybody, yes. I'm just a scared anesthesiologist among many, and we're going to talk about some things that tend to make anesthesiologists stay up late at night or sweat a little bit, and why that may be the case for patients with Down syndrome. Not just Down syndrome, we're going to touch on some neurodivergent pieces that may cross other populations too. And then at the end, I hope there'll be some information about bits of stuff that clinicians from the outside of the anesthesia world, when they're making a referral for sedation or anesthesia services to somebody, whether that's for diagnostic procedures or therapeutic procedures, might be able to include in their H&Ps or their referral information that is immensely helpful to us as we plan and execute sedation and anesthesia for patients with Down syndrome. So a couple of things about anesthesiologists. They try really hard to look smug or cocky, but most of us, most of the time, can barely attain looking tired or beat down. And the second piece is that anesthesiologists are, by definition, obsessive compulsive. We're control freaks. We tend to want the same patients with the same anesthetics and the same procedures the same way every time. And so if that doesn't happen late at night when we're looking at the surgery schedule for tomorrow, and the procedures aren't going to be the same, or the patients aren't going to be the same, or the anesthetics aren't going to be the same, that's when we start to sweat. And if we actually see neurodivergent populations on the patients on the surgery schedule, then we may make other faces too. Unfortunately, I see that a lot in my colleagues. But to kind of get it to why that may be the case, it's important to start speaking in terms of what worries an anesthesiologist overall. At the 30,000 foot level, I know that you're all familiar with the resource allocation versus reimbursement conundrum. As an anesthesiologist, as we drill a little closer to the ground, then everything distills into questions about air hydraulics and time. And specifically, that means airway management for the most part, hemodynamics management, and production management. That's an unfortunate ever-present pressure in our environment. So the key piece when I'm trying to think in terms of what's going to be needed for resource allocation or for planning in sedation or anesthesia for a neurodivergent patient, and particularly patients with Down syndrome, you'll notice that everything on this slide applies to people with Down syndrome, and it applies regardless of age, gender, or body habitus. I'm going to say that a few times during the course of this presentation, but neck is a pretty common phenomenon, and that may be a discussion for a different day in some ways. Airway size, obstruction, the ability to get oxygen in and carbon dioxide out, autonomic stability, in particular, some things about bradycardia and asystole that may come up in a little bit, and then the time piece. I'm going to say these words to you that I'm going to come back to over and over in the next few minutes: participation, preoperative time, and postoperative time. There's a phrase at the bottom of this, emergence delirium, that you may not be familiar with. I'm happy to touch on that if somebody wants to ask me about that a little bit later, but for purposes of respecting your time, I'm going to pass that for a little later. When I'm at the bedside, however, in a preoperative setting, trying to gather information from a patient with Down syndrome or their family, there are some things I'm obviously looking for, and some things that I look for that I may not be able to get. And thereby, it might be a little surprising at some of the information that I may rely on other people to provide for me, meaning the referring clinician in particular may be helpful in that regard. Certainly, cervical spine stability if there's a question in the patient. Baseline pulse ox, because somebody who's not able to participate in getting vital signs in a preoperative setting for any reason, I can't get a pulse ox on them until they're sedated. Well, then I don't know what their baseline pulse ox is for when they get into recovery room, and I'll come back to why that's important. BMI certainly is always a concern in this population from an anesthesia perspective. Baseline heart rate and blood pressure, for the same reasons I may not be able to get a pulse ox on somebody, knowing what their baseline heart rate and blood pressure is can be immensely helpful in planning and executing their sedation and anesthesia in a safe way. Obviously, if they have palliated or unpalliated CV defects, if you can reference some recent CV eval, especially if it references valve function or ventricular function, presence or absence of cardiomyopathy, pictures can be helpful. And I already touched base on that bradycardia or asystole with previous anesthetics. That happens much more commonly than you might find reported in literature. And it's important, if you know something about past experiences in the population, their families may speak in terms of them coding or dying under anesthesia. We hope that that's not ever the case, but that's what families come away with when they're traumatized by an anesthesiologist who tells them that their patient, their family, their loved one tried to die on the table. And timing. So the preoperative and postoperative periods are the pieces that I have the least amount of control over, because, quite frankly, the patient is awake in those scenarios, or is waking, is prior to sleep and then post sleep. So their ability to be safe in the space with themselves or with others, to communicate their needs, or me to understand their attempts at communicating their needs, whether they're going to stay in the space. And then that reference to emergent delirium, I said earlier, if they have a history, if their family describes a history of them waking up angry or wild in PACU, that can affect their ability to get up and get out of the building safely. This is not my dog, but it appears to be a happy dog. So I referenced neck and atlantoaxial instability earlier. Here's a reality I've already touched on about whether they can participate in getting vital signs. People who can't participate or not able to participate in getting vital signs probably aren't going to participate in getting flexion extension films, or probably not going to participate in an MRI or a CT scan without sedation or anesthesia. And that's kind of oxymoronic. If we're doing sedation or anesthesia to get flexion and extension films or CT scan of the neck so that we can do sedation or anesthesia for another procedure, the reality is that simple documentation about movement, voluntary movement of the neck, whether around the bed from side to side, if they track you as you move, or up or down if they're looking at your hand or following your iPhone, that's great information for me to have about their ability to, about my ability to manipulate their neck, even within a range that's marginal, and keep them safe from a neck stability perspective. So anesthesiologists are always worried about airway. The Malampati classification, if you're not familiar with that, was developed with the intention to try and predict who would be difficult to manipulate from an airway perspective, in particular, who would be difficult to intubate. It turns out that it's a very poor, it's very insensitive to difficult intubation, but it's very sensitive to predicting who will obstruct when they go to sleep. And as you can tell, so the intention, just to break it down easily, is that if you could see past the tongue into where the tonsils would be, then they're probably easy to intubate. And the truth is, if you can see past their tongue into where the tonsils would be, chances are they're not going to obstruct much when they go to when they go to sleep, whether they go to sleep naturally or they go to sleep because I forced them to sleep. But if you can't see past those things, then the likelihood is high that they will obstruct. And there is just a marginal, about 40% of the time, which is very low, some sensitivity that can predict a difficult intubation. People with Down syndrome, regardless of age, gender, or body habitus, will exhibit a Malampati 4 exam every time, virtually 100% of the time. Now that I've said it, you'll all remember a case where that wasn't true, but that proves the rule that virtually 100% of the time, human beings, regardless of body habitus, if they have Down syndrome, will exhibit a Malampati 4 exam unless they've had surgical or radiation altering of the tongue or jawline. So a test that is much more sensitive to difficulty for intubation and thereby important to an anesthesia provider and much easier to evaluate from the perspective of a non-anesthesiologist, but can be immensely valuable to me when I'm planning for sedation or anesthesia in somebody, is the mandibular protrusion test, which is a fancy way of asking whether or not somebody can bite their upper lip. If they can extend their jaw past their upper teeth, better than 95% of the time, they'll be easy to intubate. That's important whether you're considering doing sedation in your office or you're sending them to the OR. And human beings with Down syndrome, even if they have a relative or de facto hypoplastic mandible, or they have an overbite, will still be able to extend their teeth past their upper lip. And that's something, again, you can get them to voluntarily do at the bedside in the clinic when they're comfortable, and then simply write that they're a Class A mandibular protrusion test or MPT, and your anesthesiologist will love you forever. Why is that important? Because obviously, if I know that if I can predict appropriately that I'll be able to see the cords without much effort, because I'm an anesthesiologist, I tend to be lazy in the application of my job for the most part. If I can see at least the back of the arytenoids, then I know where I'm putting the tube when I'm looking directly at the glottic opening. But you see this kind of semicircle smile line right here underneath the back? That's actually the esophagus. In its natural state in a sedated patient, the esophagus is not open for me to look at. If I cannot see the glottic opening, such as in these spaces, to put my tube in, I'm not sure if I'm going here or I'm going here. And just for clarification, putting the endotracheal tube in the esophagus is bad. So last piece of this, I referenced preoperative time and postoperative time taking up being the most vulnerable time period in an anesthesia provision or time management of anesthesia provision scenario. It turns out that if you combine all of the physiologic differences or comorbidities in patients across neurodivergent populations, including patients with Down syndrome, that stuff doesn't cost me a lot of time. The skill set and equipment and medicines that we have help us manage those, particularly intraoperatively quickly, and not disrupt turnaround time or gate to gate time from case to case or plane flight to plane flight, to borrow an overused metaphor. So if you remove those things, if you just remove the comorbidities piece, I'm still left with a bunch of questions about helping patients with Down syndrome be comfortable and safe and receive compassionate care throughout their perioperative experience. Again, preoperative and postoperative time pieces are the most vulnerable for me to be able to manage and them be able to participate. So if I can know some things about their sensory or behavioral management needs before they get to me, or I can assess those things in the preoperative area successfully, then I can plan appropriately to help them have a better experience and me as well. What we did at Arkansas Children's Hospital in UAMS a number of years ago was then take these questions, simply apply a point value to them so that we could rapidly assess whether we were in an ER, in a trauma bay, or we were in an ASC setting or a clinical setting or the main OR, what might be needed to help them make it comfortably into the building, into a preoperative setting, and then get out of the building comfortably as well. We took those questions and those point values, and it's a very simple scale, but by grading the scale, it helped us determine who was going to need the most resources and how we might need better to apply them, again, preoperatively and postoperatively. This is a gratuitous picture of my son who has trisomy 21. And just for the nerdishness, your potentially nerdish questions, he does exhibit a Mallampati 4 exam, and he does exhibit a Class A mandibular protrusion test. So after all that's said, the pieces that are most helpful for me as an anesthesia provider that I may not be able to have access to preoperatively and intraoperatively, that I rely on other people to gather, or other people to have considered gathering and then transmitting to me either in an H&P or in a referral note, are going to be something about neck movement, something about airway predictability, whether it's Mallampati, if you like Mallampati, that's still helpful, but I'm going to reassess at the bedside. But mandibular protrusion test, they may not participate for me in a mandible protrusion test, but they're more likely to participate with you in the clinic setting. Their BMI, or at least a height and weight, so I can figure BMI for medication calculation and post-operative respiratory needs. Sensory management or sensory assessment of some kind. I'm not trying to sell you on this rapid sensory assessment that we use, but something like that speaks to my ability to communicate with them, or their ability to communicate with me, their ability to be safe in the environment, their ability to transition from space to space or across thresholds, like changes in colors in the floor or up and down stairs. And then baseline vital signs. Who knew? Baseline vital signs can be nearly impossible to collect on neurodivergent human beings if they're agitated or upset and scared in a preoperative environment. So if you can provide for me a pulse ox, a baseline pulse ox that says this patient lives at a pulse ox of 93, then I'm not forcing them to be admitted to the hospital out of PACU because they don't have a pulse ox of 95 or better without oxygen supplementation. I'm sorry if I ran over. I do tend to talk a little long, but I'm happy to answer some questions or punt questions to after the end of the case presentation for time purposes.
I think we have some time for a few questions. That was very helpful from a standpoint of someone who refers to the anesthesiologist to know what I have not been sending you. So I will get better with my next one.
We have a question from Mary Stevens.
Hi, can you guys hear me this time? Thank goodness. Of course, not the time I'm presenting. James, that was great. Good to see you after a couple of years. I love your slides because I think there's things I could do better. So I have a question that came up this week. We had a patient, didn't have Down syndrome, but currently could have, is on anti-epileptics and can't swallow pills. So was told at the Children's Hospital they could take their crushed Keppra and a small amount of applesauce. They confirmed with the team the night before, we're told yes, and anesthesia balked when they arrived and bumped them to be the 4 p.m. case, which really made for a long day in a busy urban hospital. Thoughts on how we might respond in the future, or better get this kiddo to the OR? I don't think he's going to learn to swallow pills.
That's an unfortunate experience in my own perioperative setting with some of my colleagues, for the same reasons that that neurodivergent patients may not be able to participate with simple things like gathering vital signs or getting an IV started. Managing medications and full stomach status, or the potential for aspiration status, is a real phenomenon in the population. So scenarios in which medications can be delivery of medications can be punted until after the case is an easy step to take. If the Keppra dose can be postponed until a PACU setting or afterwards, then that's the easiest way to avoid that phenomenon, because I can only speak for me. I cannot speak for other providers. I try to teach providers that applesauce, a few cc's in the stomach, may not be likely to produce an aspiration event. But the tough reality is that if there had been an aspiration event, the family would have been more upset than they are that things were postponed. And that's a crass perspective, but the anesthesia provider in that scenario is trying to weigh the risk of an aspiration event with a particulate matter, and thereby the potential for pneumonitis, ICU intubation stay or worse, versus postponing the case until you're past that time window. For things that can't be postponed, taking them a little earlier, a couple of hours earlier than you might otherwise take them, is also another option for the family. Here's something that I try to communicate to families about taking medications like that. If it is going to have to be taken in sauce versus a syrup form or a dissolved form in a clear liquid, the anesthesiologist can deliver the medicine intraoperatively. There are methods to deliver their anti-seizure medicines or similar anti-seizure medicines if that's a significant enough concern. Conversation with an anesthesiologist preoperatively can help plan for that scenario. It's unfortunate that you faced that this time.
Someone else asked also about a PharmD consult beforehand. Would that be, or would just seeing the anesthesiologist be more appropriate? What would you recommend?
Well, it's great to have the PharmD consult, especially if you're trying to consider whether or not the Keppra dose is needed badly enough that we can't postpone it. We need to find another route for delivery or an alternative medication to deliver within the time window we're talking about. But at the point of the pre-op evaluation, it'll be the anesthesiologist that you have to communicate to, because they're the ones that are frankly putting their license in front of you and risking that potentially deadly aspiration event, as rare as that is.
We have two more questions. I think first Peter and then Nikki.
Great. Hi, Peter Bolova from the University of Pittsburgh. James, thanks for a great talk. My concern is always the post-operative recovery, and if there's anything that we can recommend as protection for patients if they do have that class 4 Mallampati airway, or things to look at in the 24 or 48 hours after surgery.
So I referenced BMI a couple of times. BMIs of 50 or greater are 4 times more likely to exhibit a difficult intubation scenario, and they're more than twice as likely to experience an airway complication post-operatively in the first 24 hours, which is one of the reasons why having a baseline pulse ox can be so important. SpO2 can be so important for the anesthesia provider in the PACU trying to determine whether the patient's safe to leave or not. Medications that may be given for sedation preoperatively can certainly impact post-operative recovery, and it's a tough reality that for patients that require large doses or relatively large doses of Versed or Versed-like medicines or combinations of Versed and ketamine, they can be sleepy and have exhibit obstructive airways for several hours post-operatively. And ketamine, certainly in doses greater than roughly 1 milligram per kilo IV or more than 3 to 5 milligrams per kilo PO, produce dysphoria and hallucination phenomenon in patients, regardless of their neurologic status. For patients who have difficulty communicating their fears or their hallucinations post-operatively, you may see that as a degradation of their baseline behavior because they're still recovering from ketamine that can hang around for 12 hours plus. So again, conversation with anesthesiologists preoperatively about dosing parameters for preoperative sedation medicines can influence postoperative recovery. It is true that intraoperatively medications, including the anesthetic gases, can influence degradation of behavior similar to what you see in patients with dementia. And in those cases, conversation with family from the referring clinician side about planning for, call me if you see these symptoms and we can help with this phenomenon. If they're on clonidine, or if it means going up on an alpha agonist or something like that to help with mood stabilization post-operatively for 24 hours, those or doubling the dose of olanzapine for 2 days. Those things are conversations that the referring clinician can help with, and the anesthesiologist involved in the case can help with, again, if they know about post-operative history in the patient. I hope that helps.
We have one more, Emily, and then we'll go on to the case.
Yeah, I didn't, I saw Carrie also had her hand raised. Nikki, did you want to go or did you?
Oh, I didn't have a question. I was actually just going to add to Dr. Stevens' question around the issue with medications, like especially seizure medications, and just wanted to offer that a lot of times the neurologist can offer a plan for when NPO that involves a substitute IV medication if there isn't an equivalent IV medication available for the seizure medicines that they're on. So that's always worth an ask. A lot of times we can cover even just with like an Ativan for a few days or something like that. So always worth considering that as well.
And then Carrie.
Hi, first, your model very much excites me, especially as a neurodivergent individual who works with neurodivergent individuals. And I think my question is partially two-parted. How widely known or discussed is the model? Because I've yet to see it practiced or employed outside, I work with adults primarily. And two, have you considered putting it on like MD-Calc or something like that?
Are you asking me about the rapid sensory assessment piece? Outside of Arkansas Children's Hospital and University of Arkansas for Medical Sciences, I'm not aware of any other institution that uses it. And the Society for Pediatric Anesthesiology has a special interest group similar to this one that I'm involved with, and there are some individual practitioners on there that have adopted the model. I'm happy to share it, but I've not made an effort to disseminate it large scale. I'm happy to consider that, or happy to help if there are institutions or groups of people that are interested in trying to utilize it or adapt it to their use. More power to them. We needed something that we could assess patients quickly in under 60 seconds, because if they're in a trauma bay, you're not going to get more than 60 seconds or 120 seconds. If they're coming in from the outside and you're trying to sedate them in the parking lot to get them into the ASC, then you're not going to have a lot of time to do the assessment. But in order to glean the information, we needed to be easy to communicate and easy to gather.
From my perspective, this could be a game changer for adults with neurodevelopmental disabilities.
Carrie, I'm happy to talk about however that might be helpful to you, and I'm happy to share it.
Thank you, James. Great presentation. I really appreciate it. For someone who does lots of pre-anesthesia evaluations, I have a little work to do. So thank you.